Good afternoon, Dr. Mario.
Hi, Angelica. Good afternoon, everybody. Welcome. We're just waiting for a couple of seconds to let people get in before we get started. We don't want to run late, and we want to also value your time. So welcome to our forum today. I've been listening to a lot of you tell me that we need to be a little more transparent and inclusive and open to gathering feedback, and Zoom is a great place to do it. Unfortunately, we don't always get together. So we're really pleased that you're here today. So we sent out an email last week basically saying we were going to do a 4-step process before making any changes to where we're headed with our COVID policies and procedures. Many of you are aware we have resolution 1, and we've been gaining feedback on should we make some changes to resolution 1, and if so, what are those changes? And we've had a return to campus work group working on a procedure for us. So thank you to our return to work to campus work group, and has done a lot of work on this. We will do a survey that's based heavily on that plan, and it'll go out, I hope, tomorrow. I'm thinking it should. Z, I don't know if you can confirm that or not if you're here. And then the feedback will go back to our return to work group and to the college leadership. Once that's done, we are scheduling another forum on May 6th to present the findings of the survey, and then planning to do some decision making around the final pieces of what we should do to resolution 1 and the implementation of our operations plan. Yes, Z?
Yes, you're correct. We getting the survey all finalized, and we actually thought we were going to do that after 1 o'clock today, but we will definitely take the extra few hours to do a little bit more tweaks on it. So we'll be ready to go out tomorrow morning.
Okay, thank you. I'm watching those emails come through. So, okay. And so as part of this, we all wanted to hear from our county public health department. And so we invited Matthew Higgs, who is the ELC program manager for the Santa Barbara County Public Health Department. And he also has brought a couple of his colleagues with him. And he's going to share where Santa Barbara is and why some of the regulations and their recommendations are the way they are. We thought it would be good for us all to hear this. So with that said, I'm actually going to turn it over to Matthew, and we have some slides. And we'll come back and we will take questions and comments all the way up to 1 o'clock. So take it away, Matt. Welcome.
Thank you. So yes, I'm Matt Higgs. I'm the ELC program manager for the Santa Barbara County Public Health Department, and I oversee our COVID response teams for vaccination, isolation and quarantine, our outbreak investigators, and our testing folks. So just wanted to go over a few things, and just to start, to sure everybody's been following the news, we've seen a drastic decrease in cases from our Omicron surge. Over the last week or two, we have seen a slight increase in cases, but we're still at what the CDC would consider a moderate transmission level. We're at the lower end of that moderate range currently. So cases are way down. They continue to stay down. We continue to look at the data and the cases as they come in, and track the new variants that are out there. So the current variant that is most prevalent is the Omicron BA.2 out there. So that's taken over as the dominant variant across the country and throughout the state of California, and locally in our county as well. So we continue to track and monitor cases, looking at hospitalizations, and just generally keeping up our surveillance for COVID within the county. With the decrease in case rates after the Omicron surge, the state, the nation, the CDC, the state, and locally, there's been a pullback in some of the mandates. So masking mandates from the state have gone away, except in very limited circumstances. And so just looking forward in how we manage COVID over the long term is kind of where we're at now. The state has published their smarter plan, which goes into some detail on how we're looking at managing COVID moving forward. So just kind of want to talk about 3 of the key areas that we look at as far as mitigation goes. So we'll go through those. Can go to the next slide. And this is just some of our team. We have our Safe Schools for All team, which is primarily focused on the K through 12 education sector, but we kind of bridge between higher education, K through 12, and our early childhood education. And joining me today are Georgine Lowe and Jan Chaitillo with our Safe Schools for All team, and there's a couple other members of our team as well there. Next slide. So just a little outline. First, we'll talk about masking, and then a little bit on ventilation and filtration and indoor air quality. And then we'll finish up with some conversation around vaccines. Next slide. So mask effectiveness in the current guidance. Next slide. So really with masking, there's 2 key factors, and we're looking at fit and filtration. So here's a little infographic from a study that was done. It was actually done in California and published by the CDC. So no mask essentially offers no protection. Cloth mask, 56% lower odds of testing positive for COVID. With a surgical mask, that goes up to 66%. And then with N95, that goes up to, or KN95, and the respirator, high filtration mask, that the odds lowered to by 83%. So the fit and the filtration of the mask are the key factors. Other things that play into that is whether the source of infection is mask versus the individual that's potentially going to be exposed to it, or if both individuals are masked. The more layers of protection and masking that are in between the two, the lower the odds of contracting COVID are going to be. So that's masking effectiveness in a nutshell. It's pretty straightforward. Masks do work. They work both as source control, so that they limit the individual spreading the virus, and then they work as personal protective equipment, especially the higher filtration mask, and prevent you from contracting the virus. Next slide. So the current masking guidance, CDPH continues to strongly recommend masking indoors. It's throughout their policies, but there's been a shift in the masking guidance away from institutional requirements to one around personal risk assessment. We've seen this both from the CDC and CDPH. What that leads to more of is that one-way masking. So potentially only the person that is going to be exposed, having that layer of protection, and potentially fewer people that may be a source of infection having that layer of protection, which increases the focus to those well-fitted high filtration masks for the individuals that are protecting themselves from infection. So switching from a cloth face mask to an N95, KN95 is going to increase that personal protection. And then we're, mindful of the potential for surges and increasing case rates, the emergence of new variants and other factors that may necessitate a return to masking mandates. And that may be at an institutional level, it could be at a county level, it could be at the state level, or based off of CDC guidance. That's going to be very dependent on what's going on. And it's not necessarily a one size fits all process. So as an organization, as an institution, it may be a matter of mandating masks when there is an outbreak within your organization, and then relaxing those mandates as your local institutional case rates go down. So it isn't necessarily an all or nothing proposition, and it can be based on the specifics of a situation at hand. So maybe during an outbreak, there's a masking requirement. During a localized surge, there's a masking requirement. But then as those case rates drop back down, masking requirements are lifted. And then just linked there is the CDPH guidance for the use of face masks. Next slide. So one of the things that has become an increased area of focus nationally at the state and the local level is the importance of indoor air quality and the necessity for ventilation and filtration of indoor air quality, not just as it relates to COVID, but its importance in reducing the transmission of other respiratory illnesses and other health benefits and societal benefits that come along with that improved air quality. So improving indoor air quality through appropriate ventilation and filtration is one of the most important mitigation tools that is available for controlling the transmission of aerosol diseases, which include COVID. So this is a way that we can look at improving our infrastructure and our engineering to benefit in reducing disease transmission as a whole, not just looking at COVID, but looking at flu, looking at RSV, looking at other viral diseases that have been an issue in these settings for a long time. With the restrictions that we've had in place because of COVID, we've seen drastic decreases in the spread of those other diseases. As we are lifting some of those COVID-based restrictions, we're seeing those cases start to come back. So, just in the last month, we had an outbreak of a non-COVID coronavirus infection in a congregate living situation. We've had cases not in this county, but in this state where schools have seen outbreaks of influenza right after the masking mandates were lifted for the K through 12 schools. So looking at other engineering tools that we can put in place to mitigate the transmission of disease is really important as we move forward. There's also research that indicates that poor indoor air quality negatively impacts performance and productivity. There's been research done on this in the school environment, where there's evidence of improved cognitive performance with improved air quality, and some in the business sector where productivity and output is improved with improved air quality. So some of the strategies for improving the indoor air quality: increase the outdoor air introduced into the building. This can be done through mechanical ventilation of the space, so air circulators and the like, or through natural ventilation, opening doors and windows in spaces and allowing that outdoor air to circulate in. Improving filtration of recirculated air, so MERV 13 air filters for heating and air systems, and potentially using portable air cleaning devices in areas. And then increasing the volume of air exchanges per hour, so that when we look at ventilation of spaces, they're calculated on air circulations per hour. The more air circulations per hour, the more improved that air quality is going to be, and that the healthier that space is. Another area beyond the respiratory disease transmission that goes along with this, that's really pertinent in our area, is wildfire smoke, and improving our air quality when we do have that smoke move in, whether it's from a fire in our local area, or we also get a lot of smoke coming in from fires outside of the county that impact our air quality. And our local air control and pollution district has that air quality gauges on their website that can really help to drive some of the factors that we may put in place to make sure that we're improving our air quality. And then again, the CDPH interim guidance for ventilation, filtration, and air quality link is there as well. Next slide. So the big topic: vaccinations, safety and effectiveness. Vaccinations are our best tool to mitigating COVID, and especially mitigating the most serious outcomes from a COVID infection. Vaccinations are our best tool for mitigating numerous diseases, whether it's influenza, measles, mumps, rubella, typhoid, you name it. We've had such great success with vaccinations over the history of public health over the last 100 years or so. And they continue to be an important tool, not just for diseases that we already know about, but for emerging diseases. And hopefully through some of the science that has come out through our experience with COVID, we'll be seeing new vaccines coming out for some of those other respiratory diseases that we don't yet have vaccines for. Next slide. So some questions on vaccination safety. So far, more than 565 million doses of the COVID-19 vaccine have been administered in the United States. That was between December 14th of 2020 as of April 11th of 2022. So we have had this massive push of these vaccines out to the community, and the data is overwhelming that the vaccines are safe. There are some side effects. I prefer to think of them as, appropriate immune response to a vaccination rather than a side effect, but you'll see them listed as side effects in a lot of places and on the vaccine labeling themselves. So common side effects: local reactions, so that's pain, redness, swelling at the site of the vaccination. That's common with all vaccinations. It's not just a COVID vaccine thing. You'll get that with pretty much any vaccine out there. And then some systemic common side effects: tiredness, headaches, muscle pain, chills, fever, nausea. kind of the same thing you see with any infection that you get, because that's the normal immune response that the body has. So those are signs that your body is having an immune response to the vaccine, which is what we want. And again, these are common side effects with all vaccines. These are not just a COVID vaccine thing. And these common side effects typically resolve within a few days. Onset usually tends to be within 24 hours of the vaccine, and usually within 48 to 72 hours, those symptoms will have resided. Next slide. So there have been some reported rare adverse events with the COVID-19 vaccines. And again, these rare adverse events occur with most vaccines. This isn't just a COVID-19 specific vaccine things. People react differently to different stressors. So in rare circumstances, there have been some serious but extremely rare adverse events. So one of those being anaphylaxis. So that's a severe allergic reaction to an allergen, in this case to the vaccine. There have been approximately 5 people per 1 million vaccinated that have had a anaphylactic reaction to the vaccine. So extremely rare. And then we get into that risk calculation of, is the risk worth the benefits, and overwhelmingly they are. Another serious but extremely rare adverse event has been thrombosis with thrombocytopenia. This has been noted with the Johnson & Johnson vaccine. There have been 60 confirmed cases out of 18.6 million doses of the Johnson & Johnson vaccine. So again, a very rare event. Those cases were primarily in women of childbearing age. So, you may want to consult with your doctor before getting the J&J vaccine if you fall into that risk category group. But again, the events have been very rare. Guillain-Barré syndrome, which has been a noted side effect with other vaccines, including the influenza vaccine. Another very rare one. The data on this is preliminary, but the reported cases have been very few. And then a big one that's been out there in the news a lot is myocarditis and pericarditis. The incidents have been associated with the mRNA vaccines, so the Moderna or the Pfizer vaccines. It's primarily been in males less than 30 years old. The majority of which have seen a quick and full recovery with no long-term complications. And the reports of those cases, again, have been extremely limited, but the data on that is still in the process of being worked out. So we don't have firm numbers on those confirmed cases yet. Next slide. So again, when we look at the risk to benefit calculations, heart complications are a known risk with a COVID infection. Myocarditis, pericarditis, heart attacks have been associated with COVID infections, and some with the long COVID having longer term cardiac issues as well. So a CDC study showed that in teen boys aged 12 to 17, the risk of heart complications from a COVID infection were 2 to 6 times greater than the risk of heart complications associated with the vaccination. And then in young men 18 to 29, the risk of complications were 7 to 8 times greater from an infection compared to after vaccination. It's also important to note that these age groups and gender group, the young men under 30, are in the population group that have a greater chance of having myocarditis or pericarditis in general. So that's just another something to note there. And next slide. So now we can talk a little bit about the vaccine effectiveness. So there is a lot of data out there now on the effectiveness of the COVID vaccine overall. This is from data published on the state's website. Shows a little bit of a trend line there. And this is a chart that I really like. And we've got this on our website for infections that shows the cases of COVID for unvaccinated versus vaccinated. And ours has been updated now for the vaccinated and boosted data as well. So this is cases from March 22nd through March 28th. There were unvaccinated individuals were 4.6 times more likely to get COVID than individuals who were vaccinated and boosted. So one of the things that we've seen, especially over the course of the Omicron surge, is that third shot, that booster dose, really is beneficial, and it's even more beneficial when we look at prevention of infection, and then we get into some of the other categories. So next slide. Here we look at hospitalizations, and the effect of being vaccinated and boosted compared to unvaccinated is even greater, with individuals that are unvaccinated 9.6 times more likely to be hospitalized with COVID than individuals that are vaccinated and boosted. And if you look at that trend through this Omicron peak here, you see much flatter lines here with our vaccinated individuals, and then our vaccinated and boosted individuals as well. And then the next slide. And then when we look at deaths, the most severe outcome from COVID, unvaccinated people were 10.6 times more likely to die from COVID than individuals that were vaccinated and boosted. So the vaccines are effective at preventing infection, preventing hospitalization, and preventing deaths, and that scales up even more as we move down this severity of symptoms. So while a vaccinated person may become infected, they're going to be much less likely to have serious negative outcomes from that infection. Next slide. And this is vaccine effectiveness versus the Omicron variant specifically. And this was data published by the FDA on the 6th of April. They looked at the two-dose vaccination effectiveness in the children 5 to 11, adolescents 12 to 17, and then adults over 18. And prevention from infection was more limited with that two-dose shot, had higher protection against emergency department or urgent care visits. So a little bit more of a severe disease where they were seeking medical attention for their COVID. We saw higher protection. In the older age group, there was some waning in the protection when we looked at Omicron. Part of that may be the disease variant itself being more infectious. And then part of it is likely the time after vaccination. So adults 18 years and older were more likely to have been vaccinated further away from the Omicron surge, where adolescents and children, especially for children, they were just authorized for vaccinations right at the time Omicron was starting to emerge in South Africa, and just getting through their vaccination series as we start to see cases in the United States and here in Santa Barbara County. So some waning with from protection for hospitalization and ED visits in the older age groups. And then they looked at the 3-dose effectiveness. Again, it's not applicable to children 5 to 11. They're not eligible for booster doses in most circumstances. Some immunocompromised children are, but in most circumstances, children 5 to 11 are not eligible for that third dose yet. Adolescents, too early to assess. They just became eligible for the third dose really right in the middle of the Omicron surge. So that data really isn't available to be able to determine the effectiveness for that. And then for adults, the third dose showed substantial additional protection for all outcomes, with limited waning for hospitalizations, especially for individuals who are immunocompetent, so they don't have any underlying immunocompromising diseases. And next slide. I think that brings us to the end there, and I'll open it up to questions.
Okay, so please raise your hand. Jim?
Hi, just wondering, do you have any data or any information on the risk of fomite or surface transmission of COVID versus airborne?
Yeah, in general, it's been found that fomite transmission is a lot less likely. So initially, the cleaning of surfaces was emphasized, but it's recognized more now that COVID is primarily an aerosolized transmitted disease, and especially with the Omicron variant. So it's still, hand washing is important. It's an important step for us to take. Cleaning surfaces, not just for prevention of COVID, but for prevention of other diseases. But it's much less of an emphasis when it comes to our mitigation efforts.
Timothy?
For the personal risk assessment guidance, what kind of guidance are you providing to people, or would you recommend providing to people for personal risk assessment?
So really, it comes down, if somebody's at increased risk of negative outcomes, so they have comorbidities, they're older, so individuals over 50 and especially over 65 need to be more concerned about their personal risk. If they haven't yet had the booster dose, their risk is going to be increased. If they have any immunocompromising conditions, so individuals that have had a transplant or have some other immunocompromising state, they're going to have a higher risk of negative outcomes. So those are the individuals that really need to look at their personal risk factors, and continue masking and maybe limiting their engagement in higher risk activities, so congregating in large indoor groups and things like that.
And then on the second part, on the flip side, what kinds of recommendations for people who are not at risk, what kind of guidance would you suggest they take?
So indoor masking is still strongly recommended. that goes for everybody. So it is still going to reduce their risk. The emphasis is now less on institutional mandates for that masking and more towards that personal risk. So that the recommendation remains the same for everybody across the board. Whether they're at higher risk or not, it's recommended that they mask indoors.
Anybody else have a question? I actually do, if nobody else is going to put their hand up. Matt, one of the things that our resolution 1 has in it is we are to mask indoors right now. We are under that order here at the college. And it seems like an overkill if you've got people sitting in like a room that have all been vaccinated, and the way we've set it up is you can only take your mask off. It's you're meeting with one person and you're not. You just got 2 people in a room in your meeting that everybody has to wear a mask, and you only take it off when you're going to drink or eat. You know, I keep walking into offices, and actually last week I dropped my guard on it. Where there's 2 people in the office, they've had their masks off. They've both agreed they're sitting there, it's comfortable. What's your thoughts about that? I feel like in some ways we overkill it, and people aren't really complying because it's overkill. And on the other side, we don't want to do anything to risk anyone.
Yeah, I think it really goes back to that guidance, and it's essentially the same guidance that we've given the K through 12 schools. Masking strongly recommended indoors, but it's not mandatory. So, you know, removing that institutional mandate is, you know, within the guidance. I think that there are other times when, you know, if we focus on the higher risk situation, so an individual that has had a known exposure to COVID and then continuing to mask, if there is currently an outbreak or an increase in cases in a building or at a campus, instituting masking around those situations as a mitigation tool. Looking at more situational response rather than a universal mandate, and continuing with that recommendation that, you know, masking indoors is strongly recommended, and ensuring that individuals feel safe to make that personal choice to mask if they choose to, and, you know, that the environment is safe for them to make those personal choices.
Thank you. Catherine.
Hi, good afternoon. My question I'd like to ask, I don't think you might have mentioned natural immunity, but I'm wondering what are the recommendations with that, and also like what are the studies that are showing the effectiveness of natural immunity, because I don't think that has been mentioned at all as part of our protection plan.
Yeah, so natural immunity, it does provide some protection. There are still a lot of outstanding questions about how much protection and for how long that protection lasts. So there was a study, I believe, out of the UK that showed that vaccinated individuals, I think, were 5 times less likely to have had a infection compared to those with a previous infection. But there isn't a whole lot of data out there, and there isn't a whole lot of availability to control and validate for the natural immunity. So, vaccination is the recommendation, whether you've had a previous infection or not. And it continues to have benefits, and there isn't any evidence that there's a negative to being vaccinated after having an infection.
Okay, thank you. Chelsea?
Hi, I apologize that I was late. So if this has already been covered, feel free to ignore. I don't think you'll necessarily have an answer for this because it's part of kind of the complex, endemic, what happens now conversation that I think people are still navigating. But I'm being curious about the impact of long COVID and how we intend to deal with that as an institution. I have a few people in my life that are close to me that have long COVID, and the implications for their lives are really real. And so I guess I'm just concerned about that. And again, I don't expect anybody to have an answer, but I just kind of wanted to bring that into the room as something that we should really be thinking about.
Yeah, and I don't have a good answer for you for that. I mean, it is something that the healthcare system overall is talking about a lot. From my perspective, looking at disease containment, that the long COVID doesn't necessarily impact that. Those individuals with long COVID aren't continuing to transmit disease, but from an overall healthcare impact, it's definitely something that is being discussed and needs to be discussed more.
Okay, thank you, Chelsea. That's a really important point. Anybody else? Questions, comments? Timothy?
So to help us better understand, like how low is the risk for people who are fully vaccinated or up to date on their vaccinations when they're making a decision whether to do different things in their life? What is like, how can you kind of summarize how low someone's risk is?
There really isn't a tool available to quantify risk. So, you can look at the rates of hospitalization or the rates of death for your specific age group, and individuals that may have similar comorbidities to yours, and get a sense of what that is. But there isn't a tool where you can say plug in your statistics and get a risk score.
And then if no one else has their hand up, I'll go to my next question. Is any ideas of changes in reporting, or is the current requirements for reporting going to maintain the same?
No current changes that we know of. There has been some discussion of potentially changing the number of cases to be considered an outbreak, but that's something that CDPH would need to do. So currently, an outbreak is considered 3 or more cases that are epidemiologically connected. That could change in the future, but we just haven't seen anything come from CDPH on that.
Okay, any more questions, comments? Are people reporting that are doing home tests? That's a question, I think, to the institution, and or maybe that is to you, Matt, because I don't think you guys get them either, right?
They are reported in limited cases. So the CDPH does have a tool available for individuals to report their home tests results, and most of the manufacturers have a reporting tool that's in there in the instructions for people to report results. They aren't reflected in the case reporting, either the county, the state, or the national case reporting data. All of that case reporting is based off of PCR testing only, and does not include antigen testing. We do know that the prevalence of at-home testing has kind of skewed the numbers a little bit, because we aren't getting as many of those at-home test kits reported to public health. As an institution, you should continue to get that. And then if you have staff or students that are reporting cases based off of those, you would still report that as an outbreak or a potential outbreak to the county based off of those antigen test reports.
Okay, thank you. I'm going to go to Rini, and then I've got two more questions in chat. So Rini?
Hi, Matt. Can you or Georgine talk about the efficacy of the antigen tests now currently, as it's, the preferred test for testing right now? Like in the most recent guidance, it says antigen test preferred. So can you talk about that? Georgine had given us a presentation to the PCW parents and students, or parents and teachers. And there was a really great slide in there that talked about antigen testing. I was wondering if she could either, go more into detail on that, or you could go into the efficacy question.
Yeah, and so the antigen testing is effective and most effective during the individual's transmissible period. So when an individual is infectious, the antigen tests have shown to be really good at identifying those individuals as positive. Where the PCR testing can pick individuals up as positive before they become infectious, and then there's a long tail on that where individuals can continue to test positive long after they've been infectious. So that's it. And the other benefit with the antigen testing is the immediacy of results. So you get the nearly real-time results from the antigen testing, and that lets individuals, isolate themselves earlier rather than if they're waiting for test results. There have been cases where individuals may be symptomatic, maybe early in their symptom onset, they test antigen negative, and then, a day, maybe two later, they test antigen positive. So there are some time gaps there that to be aware of. And if people continue to have symptoms, a repeat antigen test or a follow-up PCR test may be beneficial. But for the most part, the data shows that antigen testing is really good at identifying those individuals in that window where they're infectious.
Okay, thank you. Thank you, Rini. Two questions that have come up. One is, are you looking at COVID spikes in wastewater data? So for the county, we have some limited wastewater data currently coming from Santa Barbara City. So that is being monitored. The wastewater data in itself is kind of a new and emerging field. So we're looking at increasing our local surveillance capacity throughout the county with wastewater surveillance. And then the state is looking at expanding wastewater surveillance as a long-term tool for COVID surveillance. Okay, thank you. And then I had a private message asking about the recommendations for masks, and I'm putting that in chat. I don't know, I'm hoping it came out okay so that people can get to it. So I don't know. You can let me know if it worked or not. Thank you, Luke. All right, great. That's a better link. Okay, yeah, you had the link on your PowerPoint. I just wanted to make sure people had it. Any other comments, questions, and anything you'd like to kind of close with today, Matt?
No, I mean, it's been a long 2 years for all of us. So thank you all for your continued work and working to keep the populations that you guys serve safe. And, you know, we'll continue to work to keep people safe and to figure out how we move through this.
Thank you. Well, we know that partnerships are really critical in all of this. So we appreciate all the help from your organization, all your staff. Thank you very much. Really appreciate it.
Oh, thank you.
Okay. All right, everybody. We'll see you back here in 2 weeks. And we will present the survey data that we get from the college. Again, thank you to Santa Barbara Public Health and Matt and his team, and see you in 2 weeks.